Welcome to the Acupuncture Outsider podcast. My name is Richard Hazel, and in the time it takes for you to commute to or from work, I hope to have shared something of interest about orthopedic acupuncture using motor points, trigger points, myofascial slings, neurofunctional acupuncture, segmental treatments, anything that crosses my mind that seems to be of interest. I hope you'll enjoy it. Hello, and welcome to another episode of the Acupuncture Outsider. This is Richard Hazel, and today I'm going to talk about foot pain in a football player. So I've been treating a football player. I think our initial first couple sessions were for things like Achilles pain and heel pain. And some, when it would get bad, it would be some foot pain. So I thought we had that all under control, and I was still doing maintenance. But because I had to go out of the country to teach and our schedules didn't sync up, this football player didn't get any acupuncture treatments from me for maybe 3 weeks or 4 weeks. And on top of just some incidents that happened in practice and games, was back to having foot pain, but not only foot pain, but in the morning, hard to even walk, and numbness in both feet. So last week, I wasn't able to fit him in at a time that would work. So he went a whole week with this horrible, horrible foot pain. Mostly in the morning, it was worse. And then as he would proceed through the day, some of the pain would decrease and some of the numbness would decrease. So we know it's muscular, but to me, instead of, I had originally been treating it as just the big and intrinsic muscles of the foot. So like foot, the toe flexors and all of that, tib posterior, of course, antagonists like the extensor digitorum longus and tib anterior. The tib anterior and tib posterior seem to get injured at the same time. They both can evert or supinate the foot. And so I tend to consider them as synergists. But anyway, so I'd really, and I'm thinking about blood flow. So I'm thinking about, gastroc soleus, things like that. So those were a given. Those had been treated regularly. But after, maybe not getting treatment for 3 or 4 weeks, this had really progressed and become not just foot pain again, but now plantar numbness, especially in the morning. So I wanted to talk to you about kind of what I went through to treat it. And based on what he was saying, they were doing everything they could in the training facility. All the medical people were doing everything they could to help, but nothing was helping. And he was highly insistent that he needed to get acupuncture and come in. So I palpated the back of the calves near the tendinous arch of the soleus to see if there was any kind of tibial nerve entrapment there that would increase the entrapment that I suspected of the tibial or plantar nerves. And there was no noticeable soreness. That it's about 5 centimeters below the popliteal fossa on both sides. He didn't seem to notice any sensitivity there, but if you treat athletes, their calves are always tight. So of course, we're still going to treat the soleus and the gastrocs regardless. And that's part of, that's part of their power on that triple extension. So it's just part of the way I'm going to treat. But and of course, I did my posterior chain protocol. So if there was any kind of slight compression of the sciatic nerve by the deep gluteal muscles, then naturally that was going to get treated anyway, because it's part of how I like to treat for athletes. So the gluteus medius, the piriformis, any the low back is always tight on athletes. So QL, the erectors, hamstrings got treated, gastroc, soleus, but the real shift in the foot pain, and this player had foot pain coming in. So in some ways that's good, because you get a better sense of if your treatment was on the right track. So so I treated when he was able to lie on his back, face up. I treated the big muscles of the foot and the small muscles of the foot. But before I did that, I wanted to palpate the tarsal tunnel to see if there was any pain there. There wasn't a lot of pain there at the time, but he said in the recent past there was pain there. They were doing some shock wave and some other things to try to address any of this sort of pain or muscular issues. So he had previously had some pain in the tarsal tunnel. But if you would feel the muscles of the leg, you would already suspect that those plantar flexors were very tight. So tib posterior definitely was going to get treated. When I pressed on the abductor hallucis in that medial part of the heel, both sides were noticeably painful. So my suspicion was the biggest entrapment of plantar nerves was in the abductor hallucis. Just if you drew a line straight down from the medial malleolus and moved just a little bit forward from there, that's about where those nerves tend to get entrapped on before they dive under the foot to innervate the lateral and the medial distribution of the plantar nerves. So that was definitely going to get treated. So what I started with, and I was thinking, okay, he's got a lot of pain in his feet, so there's definitely some contracture of the intrinsic muscles like the flexor digitorum brevis. So my first 10 minutes of electric stim at 1 hertz was the following muscles: tibialis posterior, flexor digitorum longus. I tested with my pointer to make sure these locations were perfect. I wanted to see the ankle invert for the tib posterior. I wanted to see toes flexing for the flexor digitorum longus. And then I did the same for the flexor digitorum brevis on the bottom of the foot. That's kind of a midway point. You find the third metatarsal, or you could say you could find the third toe, go to the base of that third toe, that interphalangeal joint, and then you go to in front of the pad of the heel, and that's your guide, those are your landmarks, and then you bisect that, and that would be your motor point for the flexor digitorum brevis. And so I got that. I did the abductor hallucis in the nerve entrapment area in the medial part of the pad of the heel, like right where the color changes, the skin tone changes on most people at that pad. So it's definitely in the abductor hallucis coming in from the side of the foot of the heel area. He definitely felt that. And when I put some electric stim on it, I even got a little of the flexor of the toes, the flexor digitorum brevis, which is great. It means I was right where those nerves were being compressed by the abductor hallucis. Both sides, same thing. And then I did the antagonist tib anterior and extensor digitorum longus and hooked it up to electric stim and got everything moving really, really well. Very happy to see the abductor hallucis moving very well on both sides for that treatment. And the flexor digitorum brevis was moving the toes. The flexor digitorum longus was moving the toes. So I know we got a lot of blood flow in there, and a lot of the contraction was released. So when I took the needles out, I asked him to walk and give me some feedback on how his feet felt. And he still had, everything felt good except for the heels. He still had heel pain. So I had to do the point that I really didn't want to have him experience, which is the quadratus plantae. It's a little more uncomfortable than the flexor digitorum brevis. You have to go, you're like lined up with the second metatarsal phalangeal joint and the front of the heel, and you bisect it. So you're just a little bit farther medial, and you're going almost right in front of where the front of the heel is, where the pad of the heel. And you need kind of a thick needle because it's a dense area. You're going through that plantar fascia. So you got to get like a 32 gauge. I don't use a 30 gauge. That's just like, it doesn't need to be that thick, but you need you need like a 0.25 by 50 millimeters to make sure you're going to get to depth. And he really felt it and did not enjoy it, but it was so focused on, getting the result that he wants, that he was willing to let me do this. And the results were miraculous. All the heel pain on both sides was gone after treating the quadratus plantae with just the pointer for 30 seconds or so. 30 seconds, maybe a little more. I just wanted to make sure I felt some good movement from that muscle before I took the needle out. And I really didn't want to risk not getting deep enough to get into the quadratus plantae. So I really did have to insert the needle, till I felt really good density and knew that I was in that muscle. But my suspicion was not only was quadratus plantae hurting his heel, but it may have also been irritating the calcaneal nerve as well. So unfortunate to have to do it, but how amazing to be able to do it. And so that was a few days ago, and I just checked in with the athletic trainer to make sure, the player was feeling better, because yesterday I wasn't going to check in because I knew he would have some discomfort from all the muscles that were treated, and it would be hard for him to say that yes, it was better, except that in the morning, hopefully it was not excruciating to walk. It was probably sore, and hopefully less numbness. So I reached out to the athletic trainer this morning just to say, how is this player doing? Because I was hopeful that he would have less pain and less numbness. And sure enough, the response from the player to the athletic trainer was much less pain and less numbness, feeling pretty good today. That's a quote. So I'm encouraged, and I had recommended that we do a follow-up soon to repeat what I did, because even though it helped, we know that without treatment for 3 or 4 weeks, a lot of the pain came back. So we're dealing with some chronic tension, and it would be wise for us to do the same treatment again soon. So the things I want to explain that are important are that the Tibial nerve can act as a can I'm sorry, the tendinous arch of the soleus can compress the tibial nerve as a double crush for foot numbness. So know this, especially for your seniors. And then the entrapment muscles for the plantar nerves, the tibial nerve, just so you, if you're new to this stuff, the tibial nerve goes down the back of the leg and straight down the back, and it will come around to the medial part of the Achilles and go right loops down behind the medial malleolus, and then takes a turn toward the front through the tarsal tunnel. And the tarsal tunnel is like this retinaculum where especially the tibialis posterior tendons tend to compress the nerves. They split to they branch into the calcaneal nerve, the medial plantar nerve, and the lateral plantar nerve. If you look it up on Google, you can find some nice graphics to show you the distribution. But those branches can get compressed in the tarsal tunnel by the abductor hallucis because the nerve is actually going through the abductor hallucis right under that medial malleolus area before it crosses over to, bifurcates. It goes to be the medial distribution for the first few toes, and then the lateral part for the toes 4, 5. There are some other things that get involved there. The Baxter nerve. There's some like sural nerve stuff over the far end on the outer part of the toe. So that's not the only sensory for the bottom of the foot, but it's a huge part. And the plantar nerves are also motor function for flexing the toes. So there's a lot going on there. But the plantar nerves are the stars of the show when it comes to the bottom of the foot. So when you're looking at numbness of the bottom of the foot, your primary things to look at should be the part of the soleus that's about 4 or 5 fingers below the popliteal fossa. And you don't have to treat it there. You can treat motor points of the soleus wherever you like, just to loosen it up. And then you need to check the tarsal tunnel by pressing on it. And you need to palpate the abductor hallucis underneath the medial malleolus area to look for pain there. And sometimes you actually want to dig your thumb in at the bottom of the foot where that quadratus plantae could be entrapping nerves. Entrapped nerves cause muscle pain on palpation. Now, there are people for whom you will not have any pain because they have had numbness for so long that they don't even feel pain in those entrapment zones. And there are people that have numbness on the bottom of their feet, and they've gone to a neurologist who has put them on gabapentin, which is a pain medication for nerves. It's a channel blocker. So it actually isn't going to help numbness. So it's kind of an odd thing. It does not make sense to me, but I have seen patients with complete numbness in their feet, and they were given gabapentin by the neurologist. And when I inquired about it, then they find out they talk to the doctor, and the doctor says, "Yeah, you don't need to take the gabapentin for your numb feet." But you'll see that, and I think that could really maybe they started out with pain and then it became numbness, and then they were still taking the gabapentin. I'm not really sure, but gabapentin does not help numbness in the feet. it's a pain medication. It's not going to give you your circulation back and get your blood flow going to the nerves so that you can feel. So those muscles are really important for plantar nerve entrapment, and you can find motor points for all of those muscles in Aldo Perotto's guide for the electromyographer. It's been around since the 70s. There are multiple editions, and it's really one of the best sources of motor point location that you're going to find as an acupuncturist who uses motor points. It's pretty widely available in multiple languages. So, and the last name, Perotto, Perotto. So, yeah, so that I wanted to share that. I'm really happy that the player's feeling better. I'm going to watch him play today on TV. And that is the episode for this week. And I hope you're having a great weekend. Take care.